Good morning. Welcome to Chapter 21.2, Orthopedic Surgery. We start out with osteogenesis, the process of bone healing. Very important to know there are 5 stages in this process. Know the difference between the stages. For instance, callus formation stage, the osteoblasts form a matrix of collagen that bridges the fracture site. That takes 3 to 4 weeks. You should know the specifics of the stages and be able to explain them to someone like me. All 5 of them. All the way through ossification and remodeling. Remember, remodeling is the maintenance state of normal bone. Is an ongoing process throughout your whole life. We talked about that in the last part of the chapter and the process involved with that and how it is regulated. Pathological bone healing is, remember, these are healing pathologies that our bone is having issues healing. When we have an avascular necrosis, the capillary network is compromised and the tissue is dying because there's not enough blood flow getting to the tissue. Compound fracture, we're talking about a break in the skin and the introduction of microorganisms. The unions are all bad, and the bone is not uniting well. It's either uniting too slowly, or in a not so correct position, or it's just not uniting at all. But the unions are all bad. Bad processes of bone healing. Compartmental syndrome is where we have a pressure buildup inside this cavity because either the fracture is broken and is bleeding and swelling, and there's a lot of fluid in there that is increasing the pressure. The pressure starts to compromise the nerves and the vascular tissues, and this can happen in both the upper and lower extremities. And it's often a case of trauma or injury. There's a fracture, or there was some type of an accident that caused excessive bleeding in that compartment. It's not always just a fracture. It may be just a vessel bleeding and increasing that pressure. Casts, you need to know the different types and of course the advantages and disadvantages of them. We talked about that quite a bit in class. Also, you should know the difference between what type of a cast is put on a patient. Remember, these casts are for immobilizing a fracture. So they are named after pretty much what they are immobilizing. And imagine yourself in a hip spica cast, with this big huge cast going all the way down one leg and across your trunk and halfway down the other side. How are you going to get around? What kind of mobility issues are you going to have? Common ortho diagnostics procedures. X-rays, we all know what an X-ray is. Important to note is the X-ray cassette drapes. The X-ray cassette slides in, and some of them either the drape flips over and covers that gap. Some of them have a little tape thing that peels off and then sticks down so that you don't have an issue with the end. And I've even seen some bags that are just like giant Ziploc bags that are sterile. They slide the cassette in and you zip it shut, and then a flap flips over to cover that. But either way, you got to be very careful of your sterility. Someone is putting a non-sterile item into some type of a bag up to you on the field, and that is an open avenue for microorganisms. Fluoroscopy, we're going to use a C-arm. It's like a live X-ray in motion. Basically watching the X-ray in real time as it occurs. And you can stop and freeze images. When there's dye involved, then you can see things light up on the screen that are taking up the dye or contrast medium. Bence-Jones protein, we're looking for a malignant process, usually multiple myeloma. And the protein, it's secreted by the bone marrow, spills into the urine where we detect it on a lab exam, and then we find out, dang, you have multiple myeloma. Not a good thing. Bone scans are, again, radioactive isotope. The bone that has abnormal activity is going to pick that isotope up and it's going to look like a dark spot on the bone, kind of an x-ray with dark spots. CT, MRI, we know those from previous instruction, and remember the CTs are slices. They can adjust the size of slice. Most of them are a millimeter, half a millimeter, but you can take a bunch of slices and look at an organ slice by slice or a body part slice by slice, and you can detect exactly where something is going on. MRI is a non-ionizing radiation image. It's using magnetic fields, so a little bit safer to the human. Very expensive. MRI machines are quite costly. Arthrocentesis, we're going to dig out some synovial fluid and we're going to look for stuff. Rheumatoid factors, we're going to find out if you have gout with uric acid. We're going to find out if you have an infection, if you have staph infection or some type of a microorganism growing in that synovial fluid. Aspiration of bone marrow, again we're looking for multiple myeloma or some type of disease that's occurring through the bone marrow. We're going to use general orthopedic instruments for the soft tissue. There's lots of different kinds of bone instruments, but the common ones that we kind of go over in class are what you see in your setups: Holman retractors, Bennett's, some places call Holman's, and Bennett's Cobras. Also, in your book there's a Lohman bone holder, and that looks like an eagle talon or a turkey foot, kind of a cool looking retractor. Ortho has a lot of specialty toys. Foot holder for arthroscopies. Vacuum beanbag for lateral positions. This thing, it's this big beanbag, and surgeon preference, there's kind of a U or a slit on one end. Some surgeons like the slit up at the top, and some like it to be facing down towards the feet. Either way, you're going to push that beanbag up against the patient, hook suction up to it, and it gets really hard, and then you pop the cap in. When you let the cap in, you can squeeze the valve, and then it deflates the beanbag. Fracture tables, mainly used for femoral nailing. Those are designed so that when you're working on that femoral nail, you're going to be able to swing the C-arm in, and it's going to be able to go over the whole operative site and up and down. More than likely you're putting an implant in that you want to see an image of to make sure you have it in the right place. Pneumatic tourniquets, we talked about quite a bit in class. And remember, the blue thing, Esmark, squeezes the blood out. That is called exsanguination. I don't know why exsanguination is a difficult term to get into your mind, but get it in there. Exsanguination, we're squeezing the blood out. What's recommended is an hour for an upper extremity, hour and a half on the thigh. Most people will go an hour on the calf if you're putting them on lower extremity. So 1 hour upper, 1.5 on the thigh. Then we got to let that down, avoid the injuries. Traction we always use to immobilize a joint, and it helps to reduce the fracture and align the body part. So we get it pulled apart so that it lines up right, and then we can continue the reduction process of that fracture. Lasers, becoming more and more involved in all types of surgery, but ortho uses them on the knees and total joints, sometimes lumbar or laminectomies. Airflow, they wear bodysuits that have airflow in them. Some ORs have laminar airflow system. It looks like a big screen on the wall that blows air the proper direction, so you have one directional airflow. The idea is that microbes can't go against that airflow, so you're blowing everything away from the sterile field. Continuous passive range of motion machines are used to inhibit adhesions mainly, but also to, like I said in class, we're trying to increase that degree of range of motion. So if you've had an injury and you've had physical therapy, you're trying to gradually gain in degrees of motion. So you may be limited to 40% at the start, and then you're moving up to 55. The machines keep the adhesions from forming and becoming the joint from becoming stiff, and at first it hurts really bad, but then as it keeps working and the pain and swelling go down, the range of motion improves. Nerve stimulation. We like to stimulate sensory nerves, and they're generally placed on the skin near the source of pain. Kind of like voodoo stuff. I'm not so big on believing in it, but it's there. Transcutaneous electric nerve stimulation. Electrical stimulation of the bone is used when we're having some of those bad union problems. Usually a delayed union, or after a debridement. We're trying to speed up that bone growth and get that wound healed a little faster. Saws, drills, and reamers you've all probably experienced inside the operating room. Lots of different kinds. They all snap together in some kind of fancy way. A lot of compression fittings where you pull the collar back, things pop in, and then they snap back. Some of them have a locking mechanism that you turn to lock or unlock. Arthroscopic equipment. Unique to ortho is the shaving stuff. You know, you have these things that can shave off tears of different ligaments. That's unique to orthopedics. Their arthroscopy stuff. Other than that, the cameras and the light source and the video stuff, that's all the same pretty much. Ortho requires a lot of supplies. There's a ton of implants. So a lot of times that's why those reps are there, is because facilities can't afford to keep piles and piles of implants laying around when they're thousands of dollars a piece. They'd have millions and millions in inventory, and you may not use some of it. So nowadays a lot of stuff is sold on consignment. Every single implant has to go through the United States FDA, and it requires documentation and tracking. And important is you can't be using different alloys in people. It breaks down the implants, causes a delay in healing, sometimes an infection. It's just bad all around. So we do not use different alloys in people, always the same. Also, the use of polymethyl methacrylate in orthopedics is bone cement. Remember, that stuff toxic to the liver. Generally not a good thing. If you're pregnant, get out of the room, because you don't want that being the cause of a birth defect. It heats up, so it's kind of fun to have in your hand. It heats up, it smells really good, and more importantly, it works really good as a cement for prosthetics. Younger people, we don't tend to cement in shoulders, and they'll do a press fit prosthesis because the bone's going to heal pretty good around that prosthesis if you're younger. When you're older, we want to cement that in because you may not have the bone processes that you had as a younger person. Suture, like I said, they use a lot of different kinds of suture. Fiber wire for tendons and meniscus. Surgical steel, putting the sternum back together. Sometimes also for tendons. Polyester is used a ton, and in different types. There's Ethibond. Hips, they'll use sometimes a Merceline tape, which is, it looks like an umbilical tape with needles on the end, and they pull the hip back together with that. Polypropylene is Prolene. That's the blue stuff. And just like fish line, it's smooth, synthetic. Nylon, sometimes used for tendon to bone. Chromic and Vicryl on the periosteum, absorbable sutures. We want that to absorb. And we talked about bone cement already. Anatomy, make sure you know the anatomy for orthopedics. I know there's a lot and the joints can get involved, but know what this stuff is. It's important to know what you're operating on and why, because often the indication is described as some type of breakdown of anatomy. The shoulder joint are the four muscles listed on the slide that are the rotator cuff. So rotator cuff repair, there's a breakdown somewhere in those muscles that we need to pull that back together. Humerus, obviously the longest and largest bone of the upper extremity, just as the femur is the lower extremity. Shoulder arthroscopy is a nice tool for, they can evaluate the shoulder problems. They can stick the scope in, see what's going on. If you need to do a cuff repair, if the joint's impinged in some way. Endoscopic equipment is nitro tank for arthroscopic powered shaver. That thing is going to kind of like a dentist drill. That runs on a nitro power. 3,000 bags of ringers with epi in them. Position, lateral, semi-fowlers. Sometimes they call it sloppy lateral too, where they won't quite be lateral, they won't be semi-fowlers, they'll be kind of like this, where you're just sort of in between those two. General anesthesia, instrumentation is up there. And a couple pictures. There's that arthroscopic probe. Just looks like a long crochet needle with a little hook on the end. Sharp and blunt trocars, very similar to laparoscopic stuff. Usually they're metal for arthroscopy. There's your shaver and different heads on it for different sizes of shaving. Shoulder joint has a labrum. That's the cartilage cuff. And when the labrum gets damaged, there's not cushion in the joint. We need to do a Bankart lesion, is where you're tearing that labrum back a little bit, and it's usually pulled apart from the joint. So a Bankart procedure is one type of procedure that we can repair that anterior dislocation of the joint. So it's usually on this side. I've torn my labrum a couple times on both sides. Putty Plat, Bristow, and Bankart are the types of procedures that you can repair that labrum with. There's some additional equipment and things for Bankart procedure with suture anchors. Bankarts can be open or arthroscopic. Acromioplasty is an impingement. So your range of motion gets bad, and the rotator cuff gets impinged on, and it causes your joint, you can't move your arm quite the way you could before, and it gets very painful to lift your arm up. So people that get these impingement injuries, they can't hardly lift their arm up past the height of their shoulder. Oscillating saws, when you're using oscillating saws in orthopedics, you will want to occasionally squirt a little bit of fluid, saline in there, to keep it from that little saw blade just bzzz, and it buzzes really fast. It starts to smoke and burn, and you don't really want that. You want to squirt it a little bit here and there so you get a nice even cut without a burn on it. The acromioplasties can be open or arthroscopic, just like the Bankart procedure. Total shoulders. These people have a lot of pain all the time, on top of the loss of movement and the joint not functioning properly. They have a lot of pain, and often there's destruction, breakdown of the bone, and we need to put a new shoulder in there. Some of the diagnostic tests, which we talked about a little bit. Aspiration, either of synovial fluid or bone marrow. So another total shoulder is going to be a general anesthesia, semi-Fowler's position. Often they're bumped up in one way or the other to be kind of a sloppy semi-Fowler's position. Goes through a little bit there about the procedure itself. Know how this procedure progresses. You will see these in clinical. And there, as I said previously, younger patients, we're going to press fit the prosthetic. Older people get some cement. Some surgeons cement everybody. It's kind of surgeon preference.